So now what we're going to talk about is hysterectomy. This is a common conversation I have with many women, and I think many women have very common concerns, which would include, number one, what is this going to feel like? How much pain is involved? The other thing is people don't have a lot of time off of work anymore to take off. And then historically, people used to think you were super limited after you have a hysterectomy, but all of those things you learn that currently with all the technology, those things just aren't true. There's a lot of ways to lead a functional life after hysterectomy, get back to being yourself. But the biggest thing that folks have is you can't escape the fact that your body gets tired when it's been done. So even though physically you can get back quickly, you're just a bit fatigued for a little while. So if you build that into the back of your head, you're not disappointed that you just don't have that full stamina afterwards, and that takes about 6 weeks to come back. But let's describe the different types of hysterectomies. Now, there's an abdominal hysterectomy where we actually make an incision. And there's two different types of incisions that can be made, usually a fan and steel, which is across the bottom, or a midline, which is up and down. And the type of incision that's necessary depends on how big your uterus is. And a lot of times that might be used for like fibroids or if someone had cancer. The type of hysterectomies I routinely do would be a laparoscopic assisted vaginal hysterectomy or vaginal hysterectomy. There's also total laparoscopic hysterectomy. It seems so confusing, but actually they're all variants of the same procedure. It's just how to get that uterus out safely. I tell folks that I do a lot of laparoscopic assisted vaginal hysterectomies because I feel that I'm the most efficient, that I can help minimize blood loss, and I find that in doing the way that I do things, that patients are able to get back to their life very quickly. And so I like that for patients because of course that's our goal, minimal pain and back to being yourself as soon as possible. And the other thing about a hysterectomy you have to realize too is that not every hysterectomy involves removing your ovaries. So just because your uterus may need to come out doesn't mean your ovaries have to come out. So you can be hormonally the same person you are after the surgery that you were before, just not have bleeding. Now, whenever I do a hysterectomy, I also usually take a woman's fallopian tubes because there's a lot of information within the last few years to suggest that maybe ovarian cancer might actually come from the fallopian tubes themselves. So why wouldn't you remove those if they are not hormonally responsive and don't do anything for a person? So if I am to leave a woman's ovaries behind, I definitely take both tubes, the uterus and the cervix. Sometimes we may take one ovary and leave the other ovary behind. Or there's other conditions that perhaps it all needs to go. But that's an individualized discussion from patient to patient. So what is involved in a hysterectomy? You would need to be prepared to be in the hospital overnight, although there are patients that go home the same day. I'm totally great with that. You would need to be off of work for about definitely 2 weeks. At 2 weeks, if patients want to go back part-time, they're certainly welcome to do that, and at full-time at 4 weeks. At 6 weeks, people will usually finally turn that corner and feel a whole bunch better. In the 6 weeks afterwards, I tell folks there's only 2 things you can't do. Don't put anything in your vagina for the first 6 weeks, and don't lift anything too heavy. But if you like to walk, if you like to lift weights, you can do that. You just want to do less heavy weight and just reps. You want to do less heavy weight and just kind of be very careful amount of the reps that you do. But you can walk. I've had some patients jog afterwards, and you just have to be in tune with your body and let your body tell you if you did too much or you didn't, or if you could do more. You can drive whenever you feel like you could slam on the brakes if a child or dog were to run out in front of you. That might be a couple days, that might be a couple weeks. People could go up and down the stairs all they want. You just have to make more trips of lighter loads in from the grocery store, but certainly you can go and bring bags in yourself. You just have to be careful. Now the procedure itself, what does it involve? Now, a total vaginal hysterectomy means everything is done via the vagina. There's no entry into the abdominal cavity from up above. A laparoscopic assisted vaginal hysterectomy just means you use a combination between up top and down below. A total laparoscopic hysterectomy usually means that most of the surgical procedure is done up top laparoscopically, although there's still a bit of it performed vaginally too. An abdominal hysterectomy, you really don't go into the vagina at all. You're just doing everything up in the abdomen. But the benefit of more minimally invasive surgery is patients get back to work quicker and it's not as painful, and less propensity for adhesions and postoperative complications. So whenever I do a laparoscopic assisted vaginal hysterectomy, how do I do that? So I say good morning to the patient the morning of surgery. They go back and go to sleep. Once they're asleep, we put their legs up just like they're having a pap smear. And then what I do is I go ahead and put 3 little incisions in their tummy, 1, 2, 3. Now, if you look on the internet, there's different sites for people's ports or those little holes that people put, but you'll find that the surgeon will put them in specific places based on how they were taught and feel most comfortable. So I tend to like to operate off the patient's left side, and so that's why 1, 2, 3. But we address both sides, even though we put holes just on one side. That's another common concern. People wake up and they think that I just address their left side. I'm like, oh no, we do it all. But once you put the camera inside, I have these 2 holes over here so that I can move my instruments. We take a look and do a complete survey of the intra-abdominal cavity. We look at the ureters, which are the tubes that go from the kidneys to the bladder, make sure they're free of where I'm operating. If I'm taking the ovaries, then I go behind the ovaries and take the blood supply behind. If I'm not, I go in front and I just kind of cruise down around the uterus to where the bladder reflects off the front of the uterus. And then I go vaginally. I kind of get in, I kind of peel the vagina off of the cervix. I get in on top of the uterus, behind the uterus to protect all of the structures in the abdomen that we don't want to mess with. And then I kind of get all the blood supply from the bottom, pull the uterus out, sew everything together, go back up top, take a look, make sure there's nothing bleeding, make sure the ureters look nice and peristalsing that urine from the kidneys to the bladder, and then we're all done. From start to finish, you know, on a basic hysterectomy, it could take me an hour, probably less, just depending on the complexity of the case. And my goal, again, is always to be efficient, but hemostatic, and just be careful with the tissue so that patients do the best afterwards. And then you'll come back to see me in 2 weeks and 6 weeks. I always tell folks the 2-week check is a, hey, how you doing? Make sure you're doing all right, take your stitches out. At 6 weeks, I take a look up inside the vagina and make sure everything is healed up well, and also do an exam at that time, because I find that patients are nervous that it's gonna hurt, or they're scared to have intercourse because what's it gonna be like? So at least when they have left the office and have had that exam, they know that they're gonna be okay.